I'm John Hinderaker, president of Center of the American Experiment. Our panelists today are Avik Roy, president of the Foundation for Research on Equal Opportunity, and Senator Karin Housley, who chairs the Minnesota Senate's Committee on Family Care and Aging. Thanks for participating in today's program.
Thanks for having us.
Thank you, John.
Start with you, Avik. You have studied and written extensively about the COVID epidemic and its impact on various demographic groups, on seniors in particular. Tell us, if you would, what's the basic learning about that?
Well, I have some slides I'd like to go through, John, if that's all right with you, to lay the table maybe and put some of the things you're seeing in Minnesota in better context. So I'm going to share my screen here, and hopefully everybody can see this now. Let me know if you can see the opening slide, and I'll get going.
Yes,
is that working? Okay, great.
Yes.
So what I'm going to do is I'm going to go through a bunch of numbers and charts here as a way of laying the table factually as to where we are right now. And if we start out, where's Minnesota relative to the country? So in this slide, what you're looking at is test cases, hospitalizations, and deaths per million residents relative to the national average. The national average is the dashed lines, and the solid lines are Minnesota. And what you see here is that while Minnesota has seen a rise in cases, that has, proportionally speaking, the national picture is worse on increased cases, and hospitalizations have not gone up in Minnesota, whereas they have risen nationally, which tells you that probably a lot of the cases you're seeing in Minnesota are in younger people who are not getting severely ill. And also the death rates are continuing, broadly speaking, to decline, though there's been a slight uptick in the past week in Minnesota. And this is what I'm getting to with this chart. What this chart is showing you, and I'm showing you Florida data because Florida actually does a nice job of breaking this out in a lot of granularity that a lot of states don't have. What this is showing you is if you are diagnosed with COVID, either because you test positive or because of other symptoms, what's the probability that you actually die of COVID-19? And the answer is, if you're over the age of 85 and you test positive for COVID, your chances of dying are pretty high, 28% in Florida. But it's basically under 0.1% if you're under the age of 35. There's a real skew to the age distribution of what it means to be diagnosed with COVID. And this is not something that's well understood in the public because everyone reads these reports about how terrible and scary COVID is. I think people don't really realize that for younger people, the risk of mortality and of hospitalization is low. And also the mortality rate, if you do get hospitalized, is low, unless, again, you're elderly. That doesn't mean young people shouldn't be careful, but it does mean that young people themselves are at much lower risk, and children in particular, of dying of COVID. So one other way to think about this is comparing it to influenza. A lot of people ask me, well, more people who are elderly die of influenza typically, so how does the risk of death from influenza compare to the risk of COVID-19 by age? And what this chart is showing you is, depending on what age bracket you're in, are you more likely to die of COVID or influenza, assuming that 200,000 people ultimately die of COVID in the United States? And what this is showing you is that basically for working age adults and the elderly, the risk of COVID is somewhat higher in terms of fatality relative to influenza, based on historical patterns of influenza. But for children, it's the other way around. Children are at much lower risk of dying of COVID-19 than they are of influenza or pneumonia in a given year. And that at least gives us some comfort around things like reopening schools for children, which we'll get into a little bit later. But it does mean we have to take the risk seriously in working age adults and the elderly. Now that gets us to the most significant problem, not just in Minnesota, but around the country, which is the share of COVID deaths that are occurring in nursing homes and assisted living facilities. And as John mentioned, at freeop.org, we were the ones who first really called attention to this problem by compiling the national statistics. And when we first started doing this work, 13 states didn't even discuss where the data was coming from. They didn't even break it out. They didn't even know what share of their COVID deaths were coming from long-term care facilities. And what's really important about this is that nationally, 45% of all deaths are taking place in long-term care facilities, but only 0.6% of Americans actually live in those facilities. So think about that for a minute. 45% of all deaths are occurring in facilities that house 0.6% of the population. And Minnesota is at the outlying end of that. 78% of all deaths in Minnesota, excuse me, have taken place in long-term care facilities, and only 1% of Minnesota residents live in those facilities. 2% of all long-term care residents have passed away of COVID-19 or with COVID-19 in Minnesota. How does this compare internationally? The statistics around the world, or at least in the countries that are reporting it, are pretty similar in terms of roughly about 45% across the developed world of people dying of COVID are dying in nursing homes or similar facilities. It's significantly higher in Canada, to take one example that's obviously relevant to Minnesotans. Now, how does that relate to what we should think about from the school standpoint? As I mentioned, the risk of dying of COVID, the risk of serious illness in children is much lower than it is in adults and the elderly. Now, one thing you hear people say is, well, that's fine, but what if the children infect their parents or infect the teachers? And the good news is we actually have a lot of experience now in Europe and other places in terms of school reopenings, and it's pretty clear that we aren't seeing a lot of infectivity, particularly of young children towards adults, which is counterintuitive because we're all familiar, if we've had kids, of getting the bugs that they pick up in school. But with COVID-19, because of the particular biology of the SARS-CoV-2 virus, we're not seeing as much infectivity, particularly with younger children, when it comes to infecting adults. Usually when children get infected with COVID, it's because the adults have given it to them, not the other way around. And here's another way to put this age skew in context. 80% of all deaths from COVID in the United States have taken place in Americans over the age of 65. And only 0.15% of COVID fatalities have taken place in Americans under 25. In other words, the Americans who go to school or college. So that's a big part of the thinking whereby we want to consider reopening both, not just preschools and primary schools, but in the appropriate situations, secondary schools, colleges, and vocational schools. Now, another question I get a lot is, well, that's all fine, Avik, but what about international? We can't learn from other countries when it comes to school reopenings because the U.S. has performed worse than every other country in the world in its COVID response. Well, that's actually not true based on the data. We haven't done great in our analysis of the pandemic and its severity across the developed world. We ranked 31 countries and we ranked the United States 23rd out of 31, which isn't terrific, obviously. But a lot of the big European countries, the UK, France, Spain, Italy, are much worse than the United States on mortality, and even though they've had strict lockdowns than the US is, and yet they've had positive experiences in terms of reopening schools. Sweden and Finland are two countries to look at as a compare and contrast. Obviously, a lot of Scandies out there in Minnesota. Sweden and the public health authorities in Sweden and Finland recently did a joint study where they looked at school reopenings in the two countries, where Sweden has had a lot more deaths and a lot more cases of COVID than Finland has because Sweden didn't really lock down. And yet, when it came to school reopenings, the two countries performed the same. They had basically no mortality in children or adults, school teachers and staff from COVID, despite the fact that the pandemic was more severe in Sweden than in Finland. So all that to say, there's a lot of reason to be hopeful that reopening schools can work, and the value of reopening schools is incredibly important, particularly for low-income kids. And I'll stop there and say, if you want to learn more about our overall research on this topic, on reopening schools, reopening the economy, you can go to our website, preop.org, or you can look up this article in the Wall Street Journal from a couple months back where we summarized our plan. Thanks a lot.
Avik, thank you for that. That's a great introduction. Senator Housley, let me turn to you now. As we saw in one of those, in that map, Minnesota is one of the very worst states in terms of the percentage of fatalities that have taken place in nursing homes and long-term care facilities. And in view of your committee responsibilities in the Minnesota Senate, you've been involved in this from the very beginning. Talk, if you would, Senator, about what happened in Minnesota and why did we lose so many people in nursing homes compared with the rest of the state?
Thanks, John and Catherine and the Center for the American Experiment for having me on today. It's something I'm extremely passionate about, being the chair of the Aging and Long-Term Care Committee in Minnesota. And it's something that I have been advocating for since we learned about the coronavirus. I want to welcome everybody that's here that has some interest in this topic, whether you have a loved one in a long-term care facility or your staff that works at one of them. Thank you for all of that you do. But Minnesota did not plan. We knew when Washington State was the first one where there was a real big outbreak at a long-term care facility, more than 80 staff members contracted it, 35 residents died, and that was at the end of February. End of February, we knew even coming over from China and from Italy, this really was going to affect our elder population. And then when Washington State had that outbreak and 35 deaths, end of February, we knew this, and Minnesota failed to plan. They didn't put any plan together until May 7th. May 7th was the first time the governor came out with the Department of Health with their 5-point bullet plan. So that's really where the failure was, right in the beginning, with not having a plan.
Can I just stop you for a second to elaborate on that? Because one of the things we saw here in Minnesota, our governor and the commissioner of health did daily press briefings on the coronavirus for a long time. Now they're doing them, I think, 3 days a week, but for a long time, daily briefings. And every day they would announce the same thing. 12 people died yesterday, 9 of them or 10 of them were in nursing homes. And you'd listen to this and kind of scratch your head like, don't you see a pattern here? Why do you think it took so long in this state before our governor and his administration responded to what was really pretty obvious?
I think they took so long because they were overwhelmed and didn't really know what they were doing. They didn't even want to be transparent. When they started coming out with all of the numbers and the data, and we could see it clearly, they just kept continuing to report just the numbers, but no plan. Like, where are you going to get your personal protective equipment? What is your plan for testing? We kept coming at them. I mean, I was daily with data practice requests, and they wouldn't give me the information that we had to actually threaten a subpoena, a legislative subpoena, to get it. So they weren't being transparent with any of their information. They weren't even telling us which facilities had cases of COVID. So if you're a family member and your mom is in a nursing home and you're going to go visit her, but you have no idea if there's actually COVID in that building or not, and they weren't releasing any of that data to us. So I don't know why they were hoarding this, along with hoarding personal protective equipment and only letting hospitals get it and not the facilities. I think they were completely overwhelmed and had no idea what they were doing, and they didn't want to let us know that they had no idea what they were doing.
Avik, let me bounce back to you with this question. As your map there that we saw a few minutes ago showed, there have been radically different results among the states in terms of the severity of the nursing home problem in comparison with the rest of the population. Why is that? What is it that some states have done well and other states have done poorly? Oops, wait a minute, Avik, I'm not hearing you. I'm
not hearing you either, Avik.
Avik, can you do something with your microphone? We just lost you there.
I apologize. Let me try that again. So I was, let me get back to the map here. So what I was going to say was that the one thing that's important to understand about the nursing home data in terms of the share of deaths occurring in nursing homes is that's one aspect of measuring performance on the nursing home front. It's not the only one. For example, one could imagine a state that has very low overall COVID-19 fatalities. It just so happens that a lot of them are in nursing homes, right? And then there are other states where there are a lot of nursing home, not a lot of overall COVID-19 fatalities, meaning the denominator is very large. And so the percentage looks smaller. This is the case in New York. The percentage of deaths occurring in nursing homes looks smaller, not because they've done a better job, but because so many other people who don't live in nursing homes have died in New York versus other states. So that's an important thing to think about here. And we actually on our website have cut this data a lot of different ways. So you can look at things like what share of nursing home residents have died from COVID, what share of the population that's in nursing homes overall has died from COVID. And you look at all that, and Minnesota is still, one of the more severe states, obviously, in terms of the nursing home piece. But the overall state of the pandemic in Minnesota is not as bad as Minnesota has not been as hard hit overall as particularly
Ovik,
some of
if
the
I could
states on
just
the
pause you there
seaboard.
for
Yep.
a second, one of the things that some of us have said here in Minnesota is that our governor issued a very draconian shutdown order. He basically shut down everything except the nursing homes.
Right.
And looking at the numbers, if he had just shut down the nursing homes and nothing else, I think we would have been a whole lot better off.
Well, this gets to the point. I'm glad you focused my comments in that way, because that's been the reason we did this analysis in the first place is we felt people were missing the ball at the state level in both directions. There was an underappreciation of, and in some cases, total ignorance of the data because they weren't even collecting the data, underappreciation of the risk to nursing homes, not supplying PPE, discharging COVID-infected people from the hospital, forcing those patients into nursing homes. There were all sorts of things that people did because they did not take seriously the threat that nursing homes, of COVID-19 nursing homes. And then on the flip side, you have these crazy lockdowns, I think particularly of your neighbors in Michigan, where the lockdown had incredible force for trivial activities that are perfectly safe, like going, they banned riding in a motorboat, but they allowed riding in a sailboat. There's been a lot of aggressive lockdowns of behavior among younger people that are safe and an ignorance of, as you say, the nursing home piece. And I think Minnesota really falls into that category. Here you have an obvious situation where literally the 80-20 of the COVID situation is protecting people at nursing homes, and Minnesota has failed to do that.
So one of the things that's gotten a lot of publicity in New York, although as you say, Avik, New York's percentage looks relatively good, but that's because they've had so many other deaths as well. But there was a lot of criticism there because they were sending infected people into the nursing homes. Now, Senator Housley, again, I'm just the casual observer reading the newspaper, but my impression is that in Minnesota, the same thing happened, that infected people, instead of being treated separately, were being sent back into nursing homes and assisted living facilities. Is that the problem, or what do you think accounts for it in this state?
Well, it's still happening in our state. When a resident or when somebody in the hospital who gets to their care isn't as critical anymore and they need to discharge them and they have COVID, they are discharging them into the nursing homes, which I've called on the governor and the Department of Health for months to stop this practice, but they're continuing to do it. And they say their data is not spreading throughout the nursing homes, but being that nearly 80% of our deaths are happening in our long-term care facilities, I would think that would be one thing that we should be looking at. But the Department of Health says that they have less than 1% that is being transmitted from those that have left the hospital into the nursing home with COVID positive cases. So I would not be comfortable as a family member having my mother in one of those facilities where they were being discharged to, but they're continuing that practice, even though in many other states they discontinued it, but we're still doing, I think we're one of 3 that are still doing it.
That's really interesting because New York was really, they had a lot of focus on them regarding this particular practice. And at one point, I think a few weeks ago, Governor Cuomo came out and they changed it. They stopped doing it. They stopped sending infecting people back into the nursing homes. And then I think Cuomo said that he didn't do it, it was somebody else's fault or something, but at least they stopped. And it sounds like in Minnesota, we haven't even done that.
And I think, each of the states got a ton of money. We got $2 billion here in the state of Minnesota of CARES Act money from the federal government. And our governor decided to spend $6 million of that on a refrigerated building to put those bodies that have died from COVID into the refrigerated building. And I have been saying all along, why aren't you spending that $6 million on a building that you can discharge patients from the hospital that have COVID into one congregate building of COVID patients? Spend the money there. Instead, we spent $6 million on this refrigerated building that has not one body.
So somebody is asking, or a couple of people are asking in the chat, where they can find the source data for all this. We manually collected all this data from state public health departments, and actually we have a Google sheet that we link to at our website that contains all the latest data and links to our sources. So you can go there and find the links to the Minnesota data or any other states that you want. It is remarkable. I'd say a couple things. One, you know, there's some people who are trying to dismiss the nursing home problem, say, well, the nursing home problem is just a product of the overall state of the pandemic in your state. So states that are more severely hit overall are having a more severe problem in nursing homes. That's no doubt a factor because the people who work in nursing homes, the staff, are resident in the communities, but it goes both directions, right? It could be that the reason why you're seeing significant community spread in certain communities is because the nursing homes have been so hard hit. And the nursing homes are kind of a petri dish or reservoir for the virus. And then the people who work in those facilities get infected and transmit it elsewhere, along with some of the policy considerations that we've been talking about. So there's going to be a lot to think about when it comes to nursing homes. And my hope is that states and the federal government start to really think hard about the oversight that we've provided to nursing homes in terms of infection controls, because there's a lot we could be doing a lot better job of making sure, because this has been a longstanding problem. The problem of nursing homes being places where infections get passed along, it's been a problem for years and years and years, and we're only seeing the really severe part of it now.
So we talked, Avik, a few minutes ago about the practice in some states of discharging infected patients when they're no longer hospitalized, sending them back into nursing homes, which has been criticized in a lot of places. Has your research pinpointed factors that you think account for the difference, why some states have performed better than others in terms of the disease in nursing homes?
We've done some analyses, me and my team, and thus far, there seem to be a lot of different factors that are at play, and we haven't been able to really isolate them. One thing we looked at closely early on, aside from just the mandates to discharge people to hospitals, which certainly hurt, is the proportion of nursing home residents who are on Medicaid, because Medicaid steers people to nursing homes, because Medicaid will pay for you to go to a nursing home, but they won't pay for someone to care for you in your own home if you need nursing home style care. So basically the people who get that home-based care are those who are not on Medicaid, those who can afford to pay privately, but those who can't afford to pay privately, they're on Medicaid, and Medicaid steers you into these congregate facilities. And so we looked at that to see if there was a correlation. At the state level, we don't see it. We may find it more as we dig into the data at the county by county or zip code by zip code level. But the problem is that data basically is not of very good quality right now, because the states have done such a bad job of reporting the data. The federal government, CMS, the Center for Medicare and Medicaid Services, is starting to require that nursing homes directly report their fatality statistics to the federal government. So we're going to be able to analyze things maybe better in that regard, more granularly over time. But as of now, we just don't. And that's been one of the big problems overall with COVID, whether it's a nursing home problem or in general. The quality of data collection at the state level really, really varies. And states that have not had the infrastructure in place to really track what's going on in their nursing homes or in their communities more broadly have been flying blind. That's why you're seeing these crazy lockdowns that have no relationship to what's actually going on the ground, because the government doesn't actually know. It's the classic Hayekian knowledge problem. They don't know what's actually happening at the ground level.
And to that point, John, if I could, the Centers for Medicaid and Medicare data, I sent the link to Catherine so she could put that in the chat. That has the state-by-state comparison, so you can get that link. And then also, the Minnesota Department of Health has their own data site that Catherine can link you guys to also, which Minnesota, they'll always keep telling you that they say that the reason that Minnesota has a higher percentage of deaths in nursing home and congregate care living is they're saying it's not apples to apples, that different states are reporting only skilled nursing homes and not pulling in the assisted living or adult foster cares or group homes. But still, even when you take that data out of the overall data, our death rate in Minnesota we're still at 78%. I was doing the numbers this morning, and it was really scary. When you just do the number of resident cases in Minnesota in our congregate care facilities, an assisted living had 1,107 cases of COVID, 331 of those passed away. In memory care, 56 of the 165 people who got COVID passed away, that's 33%. And in nursing homes, 801 out of the 2,570 passed away, so it's 31%. So if you were living in one of these facilities and you got COVID, your chances of not making it through were 32%, which is scary.
Yeah, that's a tough number. You were quoted in an article in the Minneapolis Star Tribune yesterday. I want to ask you about, Senator. And I think you earlier on today, you mentioned that the administration here in Minnesota didn't really do anything about the nursing home situation until May. They announced a 5-point plan or something, and they started trying to do something. And then there was an article in the paper yesterday that was kind of touting the fact that nursing home deaths and assisted living deaths have declined, very substantially. And you were quoted in that rather skeptically in that article. Talk about that a little bit, if you would. What did they finally start doing after the middle of May, and what impact do you see it having?
I was pretty upset yesterday with the press conference because they were almost patting themselves on the back because now they finally have got it under control. And in the peak at the end of May, we lost 35 people to COVID, and yesterday I think it was just 3. But we should not be patting ourselves on the back because it was a complete failure out of the gate. To not plan for this and to just sit and wait. They had no personal protective equipment. Our long-term care facilities were begging for it. They were using rain ponchos for personal protective. Everybody was making their own masks, yet the state was still hoarding, and I'm not kidding, they were hoarding and holding all of this personal protective gear that they had and saving it for the hospitals, yet people were dying 10s and 20s daily, and they still failed to prepare. And then April 28th, I think they found out that the federal government wasn't sending them any more PPE. So then they were like, oh no, now what do we do? And they did not plan up until that point. So then, and honestly, this was like daily, weekly press releases demanding get a plan together. So not until May 7th. So all of these homes, these long-term care facilities, nobody was wearing personal protective equipment, and they had no plan for testing the residents and the staff members. And we know that the virus was brought into these homes from staff members, but nobody was getting tested. There was no plan on who was going to pay for the testing. And still to this day, that becomes a problem. Yet it was back in June 9th, they offered free testing for anybody who was at the protest. They called in the National Guard to do testing for those who were protesting over the George Floyd death. So they really failed to prioritize those residents of long-term care facility where we knew almost 80% of our deaths were happening, and they failed to protect them.
Yeah, I would just amplify that. The point about hoarding the PPE and not distributing it to the nursing homes and the long-term care facilities, that was a big problem in New York as well. And you contrast it to Florida. Florida, by the way, has had a very relatively low share of nursing home deaths from COVID, at least relative to Minnesota. It's more in the middle of the range, and low overall deaths, even despite the recent outbreak. And a big part of why is the Governor DeSantis there and Mary Mayhew, the health commissioner, they went out of their way to say, no, we are not going to let hospitals discharge infected patients to nursing homes. And they halted visitation. So relatives of nursing home residents couldn't visit their loved ones, which was obviously a bitter pill or a tough pill to swallow, but they did it, and that helped protect people in Florida. And the other thing they did was they really prioritized distributing PPE to the long-term care facilities, because their whole thought process was, if you prioritize the hospitals and not the nursing homes, what's going to happen? All the people who get seriously ill in the nursing homes are going to end up in the hospital. So what good is that? And that's the exact opposite of what they did in New York, New Jersey, and these other states, where they forced people out of the hospital into the nursing homes, which only meant they ended up with more people in the hospitals in the long run and overwhelming their hospitals. So it was an incredibly bad thought process that comes from, I think, a lot of some of the, well, I shouldn't say a lot, but a lot of the public health academics whose training in epidemics or pandemics is driven by influenza pandemics in the past. And COVID-19, the coronavirus, is very different in its behavior than your typical influenza type virus. And so when you use an influenza playbook, which involves things like school closures and involves things like focusing on hospitals and ventilators, COVID is different. In fact, it may turn out that ventilators aren't actually that useful. The ventilators end up killing a lot of people. That's what they found in New York. 80% of the people on ventilators ended up dying. So a lot of the stuff we did early on turned out to be wrong because it was built off of an influenza playbook, as opposed to recognizing that this is a new virus that's going to behave in new and different ways. And the people, the states and the localities that have performed the best have been the ones that really were data-driven, collecting the data, having visibility into the data, and then responding to the data by adjusting what they were doing.
And to that point too, Avik,
go ahead, Karin.
I think that's exactly what Minnesota didn't do. They didn't collect the data properly. They didn't even look at it. And then they didn't get creative and think out of the box. Like in Maryland, the governor's wife, who happens to be from Korea, I think Minnesota was just sitting on their hands waiting for the federal government to come in and save them. And other states went, we can't sit and wait for the federal government. We're going to go off on our own path. And Maryland, his wife, actually got a plane, flew to Korea, and picked up PPE and brought it back to their state. So I think those governors that actually did look at the data and think outside the box and did something for their state specifically were much more successful than sitting on their hands.
Well, if I could just toss in a personal note here too. I mean, some of this I think is fairly simple. I'm from South Dakota, which has done very, very well in terms of COVID response. If you look at the numbers, and very well with respect to nursing homes. My father's 98 living in a nursing home in South Dakota. And there was 4 months where we couldn't visit him, period. I mean, it was shut down. And they really, if you look at the numbers, seem to have avoided the problem. And it seems like that's part of the solution. Is it's kind of painful, but if you do it, it'll save a lot of misery.
Yeah, I'm putting up the map right now. You can see, if you compare and contrast North Dakota, Minnesota, and South Dakota, you see a pretty striking difference there. And I haven't dug into the South Dakota policies, but so it's interesting here, John, to hear your perspective on that. But isolating people in nursing homes is really important.
Well, you know,
unfortunately, it's hard on them, but it's important for their health.
Yeah, but it's better than the alternative of having COVID rampaging through the nursing home. So South Dakota was one of the few states, maybe the only state, that never did order a shutdown. The governor just refused to do it. But
under a lot of pressure, yeah.
Yeah, but the nursing homes did shut down, and that seemed to be a pretty good trade-off. Avik, I've got a question for you that's not limited to the nursing homes, but it's something I've wondered about a lot as I've tried to follow the data on COVID. And that is, what is being counted as a COVID death? Is it consistent around the country, or does it vary from place to place? And I ask the question in part because the most candid answer I've ever seen to that question came from the head of the health department in Illinois, who said in a press conference, if we classify something as a COVID death, we are not saying it was the cause of death. If somebody is terminally ill with cancer and in hospice care and dies of cancer, but at the same time was diagnosed as having COVID, we count that as a COVID death. We are not saying that it was the cause of the death. Now, do you know about this, Avik? I mean, what are we seeing around the country? Are states consistent, or are they counting deaths differently?
Well, the Centers for Disease Control and Prevention nationally, that's the standard they use. Basically, if you're diagnosed with COVID-19 because you test positive, whatever the cause of death actually was, you're being counted as a COVID-19 fatality. And while states had different standards originally, I think most states are now using that standard to report fatalities. So there was some heterogeneity in the beginning, but now there's a bit less of that. Internationally, there's a wide spectrum as well in terms of what states are reporting. And what we often do when we look at international data, I showed you that green and yellow and orange table. I can, in fact, put that up again. And what this will show you is that another measure that people are using to look at this, because there's debates on both sides. Some people say we're overcounting, not just because of what you just mentioned, the point of diagnoses that have nothing to do with the actual cause of death, but also because hospitals get a 20% bonus from Medicare if they count a death as a COVID-19 death versus just a garden variety heart attack. So hospitals are pressuring their emergency room staff and physicians to report and code things as COVID-19 if they have an excuse to for that bonus. On the flip side, there's an argument among some people that's legitimate that there are people who are not being counted as COVID-19 deaths. They're dying in their sleep at home, but maybe they had COVID, and we just don't know. And so a way to reconcile all that and try to have a uniform way of thinking about it is what's called excess mortality. So what you do is you look at how many people died this week in the United States or in Minnesota and compare that to the historical averages. How many people usually die in this week in July in Minnesota or in the country? And if you look at those excess mortality statistics, what's interesting is the US performs a little bit better than even on the overall mortality statistics, which suggests that maybe what's going on is the US is on the overcounting side. So you see here, the US ranks number 23 overall in our analysis. The excess mortality is 23% compared to what it usually is in a given year up to this point. The countries that have really performed badly on that score are Spain, Italy, the UK, and Belgium. France, the Netherlands, the US, and Sweden are all kind of in this middle range. We have a lot of countries that we don't have the demographic data to really count this the right way. But this, and actually what's really interesting about this as well is that today, if you actually look at this week's death statistics in the US, we're right about where the normal death count is at this time of year. So in other words, there's no excess mortality right now. Cumulatively this year there has been of about, I think, 40,000 people. Or maybe it's more than that. It's higher than that. But today we're not seeing that. So and that indicates that it may be that we're getting to a point where no matter what the rise in death counts is in cases right now, overall the scale of the pandemic is something that in context is not as horrendous as it certainly was in, say, April and in late March.
You know, to your point about the financial incentives that are in place to get hospitals and doctors to classify deaths in the COVID category, it reminds me of the joke in the 1990s. In sub-Saharan Africa, if a guy got run over by a truck, they'd fill out the death certificate, cause of death, AIDS. And there's a allegedly huge number of people dying from AIDS in Africa. Well, they weren't really, but there was no money in traffic accidents, but there was money in AIDS. And so we saw this upsurge in AIDS being listed on death certificates. Senator Housley, we had this controversy in Minnesota with your colleague, Scott Jensen, who is a Republican senator and also a doctor. And he publicly blew the whistle on the fact that doctors in Minnesota were being pressured to list COVID on death certificates. Tell our audience about that a bit.
Yeah, we are fortunate in the Minnesota Senate to have Dr. Jensen as one of our colleagues and the state senator. And he's been on Laura Ingraham many times. He's our famous senator now. But he actually showed us the document from the Minnesota Department of Health that instructed physicians, if they suspected that a person who had died had COVID, to list COVID as the cause of death. And he said never in his entire career, if they suspected somebody had pneumonia, would they write pneumonia. You would actually write what the actual cause of death was. So there were so many cases that I'm sure were listed as cause of death COVID-19 when it actually wasn't. So he called on them to change that because they were being instructed to do it that way, which they have since then. And I actually had a friend in Minnesota whose father died and they listed COVID-19 as the cause of death when she knew that he had heart disease and he was already in hospice dying from heart disease. And then they found out he had COVID, but that's not why he died. He had heart disease and he was already dying. So, and then she had to pay to get it changed on the death certificate, which doesn't make any sense. But yeah, that's what happened in Minnesota.
And as a reward for stepping forward and blowing the whistle on the instruction that was going out to physicians, instead of being congratulated for bringing that to light, Dr. Jensen has been subjected to an ethics investigation.
Yeah, it's government. That's big government for you. Mm-hmm.
There's a couple more things I want to talk about before we wrap up and take a few questions from our viewers. Let me ask this question first. I'll ask you, Avik, and then Senator Housley. We're not the COVID epidemic is obviously not over, although, as you said, Avik, it is. We're at a point now where we're back to normal levels of mortality, overall mortality, which is a hugely important thing in my view. But now that we have the experience of dealing with COVID, we're lucky, in my opinion, that this disease isn't worse. I think we're ultimately going to find that COVID has got a case fatality rate of maybe 0.2, between 0.2 and 0.3 compared to 0.1, which would be a typical seasonal flu. We could easily have a pandemic where the disease has got 10 times that rate of lethality. And so that being the case, what do you think are the lessons that we should be learning to be better prepared next time we have an epidemic like this?
Well, first I'd just say that there's a lot of evidence that we've already had different strains of SARS-CoV-2, the coronavirus, with different levels of lethality, different levels of virulence. The strain of the virus that went east from China through the Pacific Rim to the west coast of the United States early on was not as virulent, it appears, as the one that went west from China into Italy, mutated there into something much more severe, and came to the east coast of the United States. And a big part of why we may be seeing this second wave, so to speak, of COVID is because that more severe, more virulent strain from the East Coast has now made its way across the country. In general, what I'd say is we have a lot to learn in terms of what we could do better. The things I would highlight are, first, we've got to do a much better job of having a decentralized approach to developing testing for new viruses. One of the key mistakes we made early on is you had the federal bureaucracy, the CDC and the FDA, go out of their way to stop independent laboratories that were trying to design tests for the SARS-CoV-2, where the sequence of the virus had been published online. We knew how to sequence it, we knew how to test for it, but the labs that could just generate the test weren't allowed to do it. The federal agents actually stopped them from doing it, which is just insane, but they were applying the law as it's written, the rules as they're written. So that was a huge mistake. Second, you've got to do a much better job of building and designing and retrofitting nursing homes and congregate facilities to have serious infection controls. This has been a long-standing problem. We've known about this problem for decades, haven't done anything about it. This has got to be the clarion call to finally put this problem behind us. And then finally, we have to have a much better system of data collection so that that policymakers can make the right decisions. We've been talking a lot today about these lockdowns, school closures, all these things that actually, if you look at the scientific evidence, don't make a lot of sense, at least the way they were designed. And we've got to do better, but we can't do better if policymakers assume, and the media reports or reports falsely, that all people are equally at risk of serious illness or death from COVID-19.
Senator Housley, let me toss the same question to you. Looking at it from the perspective of a senator in a particular state, what lessons would you take away so that a given state, whether it's Minnesota or somebody else, can be better prepared next time we have an epidemic like this?
Yeah, collecting the data correctly out of the gate is extremely important, and prohibiting those independent private companies to develop testing was a big mistake too. I think entrepreneurship in our country and in our state should be encouraged, and that was a big mistake when this testing was halted. That testing is the most important thing, I think, when it comes to stopping any of these diseases. And then again, the infectious disease control in these nursing homes, where once we know who it affects mostly and who these viruses attack, which we did learn early on that it was going to be seniors over the age of 75, all energy needs to be put there instead of still scrambling, going all over the place. When we had the data early on, and ignoring the data and not coming up with the plan was the biggest mistake that we made in Minnesota, and that needs to be fixed.
Well, one thing that's going on now, of course, we're in mid to late July, I guess, sad to say, the summer's flying by. And here in Minnesota, we're having a controversy about opening the schools in the fall. Like most places, the schools closed around, March, and went online for the last part of the spring. And now there's a lot of doubt about whether the schools will reopen or on what basis they'll reopen in the fall. Senator Housley, your thoughts on that?
I'm outdoor knocking. We're in a campaign season right now, so I'm outdoor knocking every single day and listening to the residents. I live in a suburban district in Minnesota. Everyone says they want our schools to be reopened and reopen them safely. So we have, and I'm still feeling there's no plan for that right now. Schools want the plan, yet we have a governor who says we're going to have one of three things: either we're not going to reopen, or we're going to reopen and do distance learning, or we're going to do a combination of both. Schools need to know, and parents want their kids back in school and get them in there safely. So that, again, in Minnesota, the legislature, we have now adjourned, and the governor has executive power, so it's all in his hands, but we are continuing to put pressure on him to get those schools reopened safely.
Well, Vic, you've written quite a bit about this, and I think it follows pretty clearly from what you've already said about the numbers, the data on who's really at risk from COVID-19. Your thoughts on opening the schools in the fall?
So we just put out a major report at freeop.org on reopening schools with a bunch of both my public health and healthcare team at freeop.org and also our education team. We go through everything from childcare to preschools to elementary schools to middle schools to high schools to colleges to vocational schools. So that's a lot of ground, and I encourage everyone to take a look at it if they're interested in this topic. The bottom line, as I led with in my opening remarks, is that we know two things that are incredibly important for thinking about school reopenings. The first is that children themselves and young people in general, people from all the way from infant, toddler level to mid-20s, are at incredibly low risk of themselves enduring serious illness or death from COVID-19. The other piece is that the youngest children, those under, say, the age of 10 or 12, are at very low risk of transmitting the virus to other adults or their parents. And so particularly the case for reopening schools is compelling for those youngest children, even in areas of the country where there are still significant outbreaks going on. And as you go up the age scale to the middle schools, and particularly the high schools and colleges, you have to be a little bit more careful. And there we have some detailed recommendations as to how to mitigate those risks.
Very interesting. Let's take some questions in the time that we have remaining from some of our viewers. This is a really interesting one to me, and I know you two are not doctors, and I'll put you on the spot, and maybe it's a question you've got a thought on, maybe it isn't. But a lot of people are putting all their eggs in the vaccine basket. And I keep saying, well, there's no guarantee that there's going to be an effective, safe vaccine ready and promulgated to hundreds of millions of people anytime soon, if ever. And one of our viewers asked, what about the fact that there appear to be multiple strains of COVID? How does that impact the feasibility of a vaccine that would cover this disease? Avik, any thoughts on that?
Well, yeah, I actually have a degree in molecular biology, went to medical school and spent 12 years investing in biotech companies. So this is something I know a lot about, actually, or at least have a lot of experience with. And I can tell you that we are way over our skis in terms of the hype from early stage vaccine developers' data and the probability of success of those vaccines. We all obviously want a vaccine to come through. We all hope for the best, but we cannot put all our eggs in the basket of a vaccine being ready to go, certainly by the end of this year or sooner. That would be shattering all existing records of vaccine development. The fastest vaccine ever developed in the history of a novel virus was the Ebola virus, which took 5 years to develop. And it's not because there's something complicated about developing a vaccine from a technical standpoint. It's that you have to actually, the manufacture of a vaccine is very complicated, even if you've got the right composition to your vaccine. And also you have to test it in a lot of people. Right? So we're talking about a vaccine that tens of millions, if not hundreds of millions of people are going to get. And so a study of 10 people is not going to cut it in terms of the toxicity, the safety, the side effects of that vaccine. And just because you generate an immune response in a small number of patients doesn't mean, as you pointed out, John, that you're going to have immunity to every single version or strain of SARS-CoV-2 that comes across the pike. So we just don't know yet. And look, we all hope for the best here, but people in Washington, and I would put Dr. Fauci at the top of this list, frankly, people who are promising, or certainly allowing their comments to be characterized as promising that there's going to be a vaccine at the end of the year, are being really irresponsible in terms of the way they're affecting kind of the way people think about this virus and how to deal with it.
Senator Housley, your thoughts on this? Are you, whether it's door knocking or talking to your colleagues or observing our administration, are you seeing this phenomenon of too much faith being put in the idea of a ready vaccine?
You surely asked the question to the right person there in Avik. Wow. Wow. You know what? Honestly, people are over it. They're not talking vaccine. They want to go out and be in their community, do it safely, and they want their kids back in school. A lot of people believe in the whole herd immunity thing, and let's just get this over with and move on. I haven't heard a ton of people putting a lot of weight in the vaccine because it is going to take a while, and so I don't think we can count on that.
I'll stay with you, Senator, for this next question. Again, coming from one of our viewers, one of the hot questions right now is about masks. And our governor either has today, or I think will later today, issue a new executive order requiring mask wearing in indoor spaces throughout the state of Minnesota. What are your thoughts on that?
Oh, it depends on, honestly, where you're living in the state. There's counties that have only had 2 cases of COVID and no deaths. Cook County up in northern Minnesota. Everybody life is normal up there. Then when you're in Minneapolis and St. Paul, it's a lot different. And then you spread out into the suburbs and it's sort of a mix of each. I can tell you one story. My husband is one of the coaches of an NHL team, and somebody got COVID, spent 30 minutes with unmasked, and that guy later in the day got his test back that he did have COVID, and ended up passing it to the other guy. But that same guy who had the COVID that same day was in a meeting with my husband, and everybody was wearing the mask 30 minutes. Each time they were 5 feet apart, not 6 feet. And none of those that were sitting around the table that were masked got it. So I do believe in close quarters, the masks work, but I don't believe that every indoor space that you go, that you have to wear a mask. There's different theories throughout the whole state, but I do know in close quarters, they do work.
Let's go to the microbiologist. Avik, what's your thought? Is it all this mania? It's so strange. You walk down the street or you go into a grocery store and all these people that look like bandits on their way to rob the bank. What's your view of this, Avik?
I'm in general in support of masks. I mean, again, the masks aren't 100% protective, but it's like, well, during the AIDS crisis in the 80s, people would say, wear a condom, practice safe sex, and people would say, well, condoms break. It's not perfect. That's true, but it still reduces the probability of exposure. And similarly here, the mask isn't perfect, especially if it's the wrong kind of mask, you wear it the wrong way, but it can reduce exposure. And if you reduce the risk of exposure even by 50%, that makes a huge difference in the overall spread of the virus. So it can make a big difference. And by the way, for those of us who are chafing at the overall lockdown and school closure and some of these other things that don't make as much sense, the more we wear masks, the more we are able to reopen the rest of the economy. So to me, people who say, well, it's an infringement on my liberty to wear a mask, it's kind of like seatbelts. When the seatbelt laws passed throughout the country in the 80s and 90s, a lot of us kind of got annoyed, but eventually we got used to it. Now we don't even think about it. We put the seatbelt on when we get in the car. And similarly here, I think masks is one of those things where it's annoying and it's an intrusion. It feels like an intrusion, but it really will make a difference, particularly in those close quarters indoor settings.
Here's another great question from one of our viewers that touches on something that we haven't really talked about thus far, and that's the models. Let me go to you, Senator Housley. Here in Minnesota, we had a model. Turned out it was concocted by a couple of graduate students over a weekend and implemented by our governor like on Monday. And he went and did a press conference that said that, I'm going from memory here, but I think the model predicted that without a shutdown, there would be 74,000 COVID deaths in Minnesota. With a shutdown, there would be 50,000 COVID deaths in Minnesota. In fact, there have been 1,000 COVID deaths in Minnesota. I mean, the model was just absurdly off the mark. Has there ever been any accountability for that, or what do people make of it?
Oh, well, we keep calling him out. Those of us in the Minnesota Senate, the Republicans anyway, are calling him out on it. But yeah, they were way inflated. Just trying to scare Minnesotans is exactly what they were doing. It was the headlines. And me, I don't have a degree in epidemiology, but I did the numbers just taking the death rate in China and applied it over here to Minnesota. And between my assistant and I, we figured there would be around 1,100 people over the age of 75 that died from COVID. That was just us back in back in March, and I told my caucus, but when he came out and said 70,000 deaths, that was absolutely ridiculous. Then he dialed it back to 40, and he was way off the mark. And they modeled all of their shutdown mandates on this one model that 2 college kids did on a weekend. And they continued with that model. They stuck by it, which is why I think they weren't so transparent in all of their data, because their data wasn't meeting this model that they thought was so spot on, which was so spot off.
Avik, if we look around the country and around the world, I know that in the UK, for example, I forget the guy's name, Ferguson maybe, who did some early modeling that turned out to be, way off the mark. I think he was predicting 2 million deaths in the US, something like that. What are your thoughts on that, Avik? I mean, was any modeling done that was really helpful, or what happened?
Very little of the modeling has been good, and I think, we could have spent an hour today, John, talking about just that. The degree to which people have assigned oracular powers to people just because they have a PhD after their name, or because they put a superscript next to a letter, and so you think, well, there's a superscript next to a letter, this must be true. Well, no. A lot of the models, the main one that's often used in the US is the IHME model from the University of Washington. Basically what the researchers there did is they took a bunch of graphs, charts of caseloads and deaths from COVID-19, and then tried out a bunch of simple math equations that mapped onto that curve and resembled its shape. Now, that's fine. That's, you can do that as an exercise, but the idea that that's going to give you any predictive power into how a pandemic is going to play out is completely anti-scientific. It's not merely unscientific, it's anti-scientific. And I think there's been a real problem. Part of the problem, of course, is that journalists aren't really good at math. So they report this stuff uncritically and say that if you dispute the models, you're somehow anti-science. And no serious researcher, I think, would agree with that statement, because we all know that if you actually try to predict the future in whatever line of work you're in, predicting the future is really hard, whether it's predicting who's going to win the World Series, or predicting the stock market, or predicting the weather, or predicting epidemiology. These are all predictions. They involve a lot of complex variables, and it's very hard. And that doesn't, look, I think the one thing is we needed to take COVID seriously. The problem is we took it seriously in the wrong way. We didn't take it seriously in nursing homes. We closed schools, which was very damaging. And we overly harmed our economy by not recognizing the ways in which we keep parts of the economy open safely while still trying to protect public health.
We've got a ton of good questions. We could keep going for a long time beyond where we're at right now, but we need to close it out here. It's 1 o'clock. Let me just toss out one more question and see if you've got some thoughts on it. We've talked about fatality rates, and people talk about hospitalization rates, case rates, and so on. But one of our viewers asked, how bad is long-term lung damage? So the survival rate is high for young people, but do they still have permanent damage? Do we need to be looking at more than just fatality rate? Well, obviously that's a good question. Certainly could be true. Thoughts on that, Avik?
Yeah, so we certainly should be looking at long-term lung damage, but the two things follow from each other. That is to say, the people who are most likely to, the age groups, or the people with this, certain demographics or health status, the people who are most at risk of dying from COVID are also the ones that are most at risk of having that long-term lung damage. Because why are they dying? They're dying because the virus is having a much more significant physiological effect on them. Why? Because the virus is more readily able to attach to their blood vessels, to their alveoli in their lungs, things like that, their capillaries, in ways that for children, for whatever reason, we don't know for sure why, but it seems pretty clear that the receptors on your blood vessels that the SARS-CoV-2 virus attaches to, children seem to not have as many of those receptors, or maybe that they have them, but they just aren't in the right configuration for the virus to attach. The virus is just not attaching to children in the same way it's attaching to the elderly. And so, yes, we have to be concerned about this lung disease and serious long-term lung damage, but we should be concerned about it in exactly the same populations for which we're concerned about mortality.
Well, it's been a great conversation. Thanks to Senator Karin Housley. Thanks to Avik Roy. Thanks to all who tuned in. And it's 1:01, so time to bring it to a halt. But thank you all for participating.
Thanks, guys.
Thank you.
See you soon.